Now, good morning, everybody. Before we start formal proceedings in a moment or two, I would just like to welcome everyone to our new hearing suite. We're delighted to be here and to be able to offer, I hope, improved facilities for witnesses, legal representatives and members of the public. We have increased capacity, as those of you in George House will have appreciated, and we look forward, therefore, to offering more people the opportunity to attend our hearings in person. In October 2023, we began taking oral evidence from people who had been impacted by the devolved strategic response to the pandemic in the health and social care sector. Mr. Gale will say more about that in these sessions. Before we hear his closing submissions, I want to personally thank every witness who attended during the last several months and shared their experiences. It's not easy to give evidence in a public forum such as this, particularly when doing so involves sharing personal and often emotional experiences. What you have all told us is shaping and steering our investigations and our questions for those responsible for making and implementing decisions. I want to assure you of the value I personally place on the information you have shared with us. I also recognise that during these hearings on health and social care, not all witnesses felt able to give oral evidence, nor was it possible to invite everyone to give oral evidence. Therefore, I want to reassure you all that by written statements to the inquiry, they have been read, analysed, and will form part of the inquiry's digest of evidence. Now, I'm coming to invite Mr. Gale to present his submissions, but before I do, I'll play the policeman for a second and say that, as you know, you've all been allocated time slots and 15-minute slots to give your submissions. I will keep you to that. I have to do it to keep the thing running on time and schedule. So I apologise. And so to forewarn you, I'll interrupt you a minute or so before you get to the end of the 15 minutes and fire a warning shot across your bows. So with that warning, can I turn please to Mr. Gale and invite him to make his closing submissions?
Thank you, my lord, and good morning. And good morning to everybody here in the room and to all those who are watching us online. As has been observed by both many in these hearings and in more general commentary, the SARS-CoV-2 virus confronted this country and indeed the world with the most pernicious and devastating public health emergency in living memory. The word unprecedented often accompanies mention of the pandemic. The word is not a synonym for unforeseeable. And as we progress in our investigations in this inquiry, we will examine critically the extent to which the authorities in Scotland were or should have been prepared for this pandemic. 4 years on from the start of what became known as the COVID-19 pandemic, we are now largely in a post-pandemic world. But for many people in Scotland, the effects of the pandemic and its imposed restrictions will live long in the memory and will continue to have an adverse effect through the loss and bereavement caused, and many will carry with them the distressing memories of their loved ones' last days and moments, or in many cases where they were unable to be with their loved ones at the end of life. That distress is compounded by having to speculate about those last minutes. For others, the immediate impact was the enforced separation from loved ones in care institutions and the isolation which came with lockdowns. For those who worked through the pandemic in the health and social care sector and those engaged in the third sector, the memories of the unremitting pressure have left their scars. The witnessing of the suffering of others while trying to protect themselves against infection. As my lord has said, we commenced hearing oral evidence in George House on the 27th of October last year in relation to the impacts of the pandemic and the strategic decisions that were taken in connection with it, all in at this stage in the context of the inquiry's health and social care portfolio. Our first witness was Jane Morrison of the Scottish COVID Bereaved Group, who spoke movingly of the circumstances which led to the death of her wife Jackie and her attendant grief and loss. Since then, we have heard oral evidence on 51 days, concluding on the 23rd of May of this year. In that period, we heard from 154 witnesses. On a number of occasions, and where we considered it appropriate, we heard from panels of witnesses. Each witness, whether as an individual or in the case of panels, spoke to a written statement, and in total we have 154 statements. At the outset of this concluding statement, on behalf of the inquiry team, I would like to express thanks to a number of people. Can I begin by expressing the inquiry's thanks to all those witnesses who have engaged with the inquiry, both in the process of providing statements and in many cases associated documents. The inquiry recognizes that for many witnesses, particularly for those who have experienced loss and/or have spoken of distressing circumstances, that process was not an easy one. Very few of our witnesses were familiar with the process of providing statements and then subsequently giving oral evidence, and the inquiry has always recognized that the circumstances which the witnesses related were ones which, if they had the choice, they would have preferred not to have gone through. The inquiry could not have assembled the evidence it now holds on health and social care impacts without the courage and fortitude of those witnesses, and we pay tribute to them. We would also like to thank and recognize the contribution of both solicitors and counsel, who represented various witnesses either individually or in groups, or who represented core participants, and who contributed to the eventual presentation of the witnesses' evidence. We would also like to acknowledge with thanks the written closing statements which various core participants have filed with the inquiry. Those have been and will continue to be analyzed, as will any further oral statements which are made in amplification of those written statements. In my capacity as co-lead counsel to the inquiry, and as the counsel leading the presentation of the evidence in this session, I am under no illusion as to the amount of work that has been involved in getting the inquiry to this day. I'd like to personally record thanks to my colleagues in the council team, to Mr. Kasky KC, Ms. Barami Advocate, Mr. Stephen Advocate, Mr. Dunlop Advocate, Ms. Trainer Advocate, and Mr. Edwards Advocate. Each member of the council team has led a number of witnesses and has been responsible for leading evidence relating to particular topics. Members of the council team, in conjunction with members of the legal team, reviewed witness statements in draft and were responsible for the selection of those witnesses who subsequently gave oral evidence. The inquiry has, as has been mentioned on a number of occasions, always endeavored to carry out its work having regard to its human rights-based and trauma-informed approaches. The inquiry has also set out, in a statement published on its website this week, its approach to considering equalities issues while undertaking its work, including hearings. We have strived to proactively provide opportunities for everyone to participate meaningfully in the inquiry's investigations and recognize the importance of working closely with a range of diverse participants and organizations in gathering evidence on impacts. With all this in mind, I asked when we began this process that prior to the leading of evidence, excuse me, that prior to the leading of evidence, that each member of the counsel team should meet with the witness together with a member of the legal team. As we progressed this exercise, it was extended to include a member of the witness support team. The purpose of this was to establish a connection between the witness and the counsel who would be leading the evidence, and to, hopefully, reassure the witness that we would endeavor to minimize the stress involved. With time slots allocated to each witness, these meetings were useful to ensure that the significant issues that the witness wished to convey to the inquiry and or to elaborate on were identified. As was repeatedly emphasized to witnesses, all the material that they provided us with in their statements would be taken into consideration by the inquiry in its ongoing analysis, and I would wish to repeat that point now. I'd also like to record my thanks to my co-lead counsel, Ms. Van der Vesthuizen KC, and her counsel team of David Turner Advocate and Mary Ellen Stewart Advocate for the assistance and support they have readily given us as we have progressed through the preparation for our hearings and the hearings themselves, and in particular the input which they gave where there was an overlap, as there frequently was, between the evidence that the witness was to give to our hearings and the matters which had relevance to the portfolios which the other team were concerned. I'm pleased to say that we managed to achieve, I think, a 100% record of counsel meeting with witnesses in advance of their giving evidence. On some occasions, there was more than one meeting. I can speak from my own perspective that I found these meetings extremely helpful, and I'm pleased that those solicitors who acted for witnesses largely confirmed that the witnesses found this process of assistance. I would also like to thank all the members of the legal team. Initially, that team was led by Joanna Bain, then by Gordon McNichol, and more recently by Pauline Reed. Their overall guidance has always been informed and welcomed. The direct responsibility for assembling the evidence which we have heard lay with teams led by Joanna Mortimer and Samantha Rohr, both deputy solicitors to the inquiry, and I pay tribute to them together with all the assistant solicitors and paralegals. The task of preparing the statements that have been used in these hearings fell initially to the inquiry's team of statement takers, and their ability to relate to and engage with witnesses and secure from them comprehensive statements was essential, and again, for their work which was carried out under a great deal of time pressure, we thank them. As I already mentioned, we involved members of the witness support team in pre-evidential hearing meetings with witnesses. We thank all of the members of the witness support team for their involvement in these meetings, but more specifically for the sensitive and supportive work that they carried out during our hearings to ensure the comfort of witnesses and their supporters. I will mention other members of the inquiry team in certain specific contexts as I proceed in this closing statement. But at this stage, I would also like to mention and thank those members of the document and evidence management team who have been responsible for presenting the various statements and other documents on the screen, for the assistance of the witnesses, and indeed everyone else who was following proceedings. And B, the team of technicians who have been responsible for recording and broadcasting our proceedings, and C, finally, the team of stenographers who have transcribed our proceedings and who have produced our transcripts. With that, which may sound a little like an Oscar acceptance speech, I can turn, I think, perhaps to the more substantial matter. which is the purpose of this opening statement. It will be appreciated that, given the number of witnesses we have heard from, a detailed resume of all that written and oral evidence is beyond what can be accommodated into a closing statement lasting just a couple of hours. I will provide a brief indication of what will be included in this closing statement in due course, but at this stage I should emphasize that while the oral evidence that we have heard is, of course, an extremely significant part of the material that the inquiry has assembled in its work to examine the impacts in the health and social care sectors, the inquiry has garnered considerable other information which will inform our work going forward. In particular, we have written statements from witnesses who did not give oral evidence, as well as other information that has been provided to the inquiry in terms of Section 21 of the Inquiry Scotland Act 2005, or has been otherwise volunteered to the inquiry. All that information will be considered in the terms in which it has been submitted. In addition, and has been publicized on the inquiry website, the inquiry has commissioned and received from academics considered to be leading authorities in their respective fields research reports relevant to the issues presently under consideration and discussion. This has included introductory scoping research into the provision of health and social care services from academic institutions, including the universities of Edinburgh and Napier, Birmingham, Highlands and Islands, Edinburgh and Glasgow. We have supplemented this with further research from Edinburgh and Napier University into additional areas which have been identified as our investigations have progressed. We have found the high-quality research which has been produced to date extremely instructive, and we are very grateful to all the academics involved in for their continued and invaluable input. We have also have material which has been received by the inquiry's Let's Be Heard team. So far, more than 5,500 people have shared their experience with the inquiry through Let's Be Heard. We heard directly from people from every local authority in Scotland, and the team has participated in or hosted more than 90 events. Many participants shared their experiences online, on paper, and some 800 participated in group discussions led by Let's Be Heard and organizations in their communities. Let's Be Heard published its preliminary findings in November 2023, and many of the experiences analyzed involved health and social care. Key impacts that participants have shared centered on communication challenges, including poor coordination between different areas of the healthcare system, and patients and their families facing challenges trying to adapt to new ways of communicating with healthcare staff. Several respondents described the impacts of the suspension of services, which resulted in missed or late diagnoses, many with tragic consequences. Many respondents recounted how they or loved ones were forced to travel by ambulance, attend hospital appointments, have major surgery, undergo cancer treatments, or give birth alone due to the COVID-19 restrictions. Many experiences shared with Let's Be Heard also centered on care homes, where respondents shared the experience of losing family members, the inability to visit loved ones, and the many difficulties in navigating the difficult rules and restrictions. People who worked in care settings shared with Let's Be Heard the poor working conditions that were impacted by staff shortages, poor access to PPE, a lack of information and rules that they did not feel able to implement. That material has been and continues to be analysed by the Let's Be Heard team, and we would like to pay tribute to Dr. Anderson and her team for the work that they have done from the very beginning of the inquiry's existence. We have also heard from organisations representing those with protected characteristics and other disadvantaged groups who have told us that the impact of the pandemic was not the same for everyone, nor did it feel equal. These insights have been instrumental in helping us consider how impacts have been felt by different communities across Scotland and any potential disparities in these impacts. It is appropriate at this stage that I give some indication of how the inquiry intends to take forward the evidence and the information that we have heard and the information that the inquiry has assembled relevant to impacts in the health and social care sector. As was explained both in the preliminary hearing in advance of this evidential session and in the opening statement which I gave on the 24th of October last year, the decision to begin the inquiry's oral hearings with evidence from those who were and continue to be affected by the pandemic and the associated strategic decisions was a quite deliberate one, guided by the desire to understand the effects that the pandemic and the associated decisions had on individuals who are receiving health and social care services, whether they were immediately and perhaps unexpectedly affected by contracting the virus, or where contracting the virus has had long-term implications, or where they were in receipt of longer-term health and social care service provision. We also wanted to understand and appreciate the effects of the pandemic and its restrictions had on those who were health and social care providers, whether they were in the NHS, the social care sector, the third sector, or were part of the legion of unpaid carers. And in that connection, we were anxious to hear from individuals and representative organisations. As the inquiry has made clear, we intend to progress from this evidential basis in the health and social care context to consideration of the implementation of the strategic decisions and the decision-making processes themselves which underpin those decisions. As has been previously stated, decisions have consequences, and an understanding of those consequences is, in the view of this inquiry, an essential element in assessing the decisions that were taken and the way in which they were implemented, and will, in our view, assist in the inquiry's task of determining whether lessons can be learned should there be a future pandemic. Having assembled the evidence from these hearings, as well as the other information to which I've made reference, the inquiry is reinforced in its view that the sequence in which evidence has been taken has been conducive to providing a wealth of informed and detailed evidence which the inquiry can take forward to the next stages of our investigations. It is the inquiry's intention to proceed to produce a detailed written narrative relating the evidence and other information that it has received in relation to impacts in the areas of health and social care. This will be just what I've said. It will be a narrative record, narrating all the impacts that the inquiry has heard about. It will not be a report in the sense of a document reaching conclusions, and in particular will not include conclusions on matters of controversy, where witnesses and informants have criticised matters of decision-making and implementation. It will, however, provide a context in which decision-making and implementation will be critically examined by the inquiry. It will also provide an enduring record of the impacts of the most significant public health emergency experienced by the people of Scotland in living memory. It is our intention to prepare a draft of this narrative by the end of this year and to publish a narrative on our website in spring 2025. As I've probably already indicated, the purpose of this closing statement is not an attempt to provide a comprehensive review of all the evidence that has been heard. The purpose is to identify certain of the significant themes which have emerged during the evidence and which we intend to pursue in our investigations going forward. In the direction issued by the Chair on 30th of April of this year regarding closing statements, it was indicated that the inquiry would find it particularly helpful if core participants who wish to make closing statements would identify those impacts that are considered A, foreseeable, B, most significant and or detrimental, and C, might have been minimized or excluded had reasonable steps been taken to do so. We are extremely grateful to those core participants who have expressed views on these matters. We accept that at this stage the inquiry has not heard evidence against which some of these matters can be fully judged, and in particular has not yet heard from decision makers. Obviously, issues covered in particular by items A and C referred to in the direction will be matters on which the inquiry will wish to consider fully the evidence available to it and reach conclusions and, where appropriate, make recommendations. That said, the inquiry is interested to know the views of those who have given evidence on the impacts that the pandemic and its restrictions had on these matters. We entirely accept that the evidence of the witnesses we have heard from does not come from the standpoint of independent expertise, or that, at this stage, is informed by the expertise of others. As has been apparent from the evidence we have heard, many of those who lived through the pandemic and lost loved ones, or had been struggling to see their loved ones in care homes, or were care providers, or the representatives of care providers, came to have an informed background which is worthy of respect and consideration. For example, the depth of knowledge shown by Miss Russell, Miss Hall, Miss Leach, and Miss Hamilton, the core representatives of the Care Home Relatives Scotland Group, and of Mrs. Waterton of the Scottish COVID Bereaved, was truly impressive. There are two distinct matters raised by core participants in written closing submissions that we feel we require to be specifically addressed at this stage. In the closing submission on behalf, closing statement rather, on behalf of the Royal College of Nursing Scotland, it is mentioned at paragraph 25 that at the time of writing, it was the college's intention to write to the First Minister seeking an amendment to the inquiry's current terms of reference so as to specifically mention long COVID, together with an amendment extending the period of the inquiry's remit, specifically to consider matters relating to long COVID. The inquiry is aware that such a letter to the First Minister has now been sent. The question of any amendment to the inquiry's terms of reference is accordingly before the First Minister awaiting his decision. The inquiry will obviously comply with any decision taken by the First Minister in this regard and any direction to the inquiry as to its terms of reference. The closing statement on behalf of Care Home Relatives Scotland, CHRS Lost Loved Ones, contains in paragraphs 40 and following a case in favour of Anne's Law, a case with which Ms. Hamilton in particular and other members of the CHRS group made powerfully in the course of their evidence. What is sought by Ms. Hamilton in terms of legislation differs from what is presently before the Scottish Parliament in terms of Clause 40 of the National Care Services Bill. As is explained by CHRS in their closing statement, Clause 40 they contend, what they describe as an insipid provision. Reference is paragraph 43. Insofar as that provision is directive only as to the minister's powers to make directions concerning visiting, it does not and fails to confer any right, and it is maintained falls short of what is required and does not comply with the human rights-based approach for which the legislation contends. On that hypothesis, and given the present position of the attendant legislative process, Care Home Relative Scotland invites, through the closing statement, the chair to play a significant role in the development of the position by making a recommendation at this stage based on the evidence thus far heard in support of the enactment of Anne's Law as sought by Ms. Hamilton and her supporters. In support of that submission, CHRS maintains that, and I quote, there would be no need to hear further evidence, for example, of policymakers, to make such a recommendation. The clear, consistent, and overwhelming evidence during these hearings would be sufficient. Whether my Lord considers that he can or should at this stage make a recommendation is, as sought by CHRS, is obviously a matter for him. As co-lead counsel to the inquiry and having been involved in the leading of the evidence thus far, which CHRS refers to, I consider that I should express my view on the matter. It is recognized that Anne's Law, as contended for by Ms. Hamilton and others, has been at the forefront of their campaign. It has been argued for both in these hearings and in other public fora. That argument has been informed and has been passionate. The role of the chair of a public inquiry does include, where appropriate, the making of recommendations as to possible legislative innovation or improvement. In the circumstances presented by this application by CHRS, it is, in my opinion, and would be my advice to your Lordship, that a recommendation should not be made at this stage. A decision has been taken by government to proceed to take forward Clause 40 in its present terms. The inquiry has not heard from either policymakers and/or legislators as to their reasoning for the present wording and its divergence from what is sought by CHRS. We are also aware that we have not heard fully from the viewpoint of those who would have to implement Anne's Law and who would have to act within its terms. Dr. McCaskill of Scottish Care did indicate in his evidence his support for Anne's Law, but that support was for the current legislative proposal. I have made my Lord aware of my advice, and I have also communicated this to the representative of CHRS. Can I turn now to consider some matters of research and background information and evidence? Before we look at some of the significant and recurring themes which emerge from these impact hearings, we would like to refer to some research that the inquiry team has carried out and prepared as background to these hearings, together with a number of matters which we consider to be significant in informing and contextualizing the evidence which we have heard. On the matter of research, can we thank Millie Lewis in particular and her team for the work that they have done. We begin with some data about the effects of the pandemic, and in particular data concerning the deaths which occurred during the period of January 2020, obviously more realistically March 2020, to December 2022, all in accordance with our terms of reference. It will probably be recalled that during the pandemic, the daily number of deaths was disclosed at press conferences conducted by the Scottish Government and in particular by the then First Minister. It was regularly said that each death was a tragedy for the families and loved ones of those who had died. Over the past months, the inquiry has heard evidence which gives much greater detail of individual deaths, and informed by that evidence, the inquiry would wish to recognize the tragedy that the pandemic has wrought on families in Scotland. The inquiry research team has investigated the available data concerning deaths in Scotland in the relevant period. This data is obtained from consideration of the monthly mortality analyses published by the National Records of Scotland. These analyses identify where COVID-19 was A, recorded as the underlying cause of death, and B, mentioned on the death certificate as either the underlying cause or a contributory factor. Firstly, in relation to deaths, data published by the, I'll just use the acronym NRS, the National Records of Scotland, indicated that there were 16,537 deaths within the period of the inquiry's terms of reference for which COVID-19 was mentioned on the death certificate as either the underlying cause or a contributory factor. NRS data indicated that in that period there were 4,489 deaths in care homes, in which COVID-19 was mentioned on the death certificate as either the underlying cause or a contributory factor. The NRS data also indicated that there were 10,700 deaths in hospitals within the period, again, where the death certificate disclosed COVID-19 as either the underlying cause or a contributory factor. We also analysed the range of ages of those who died from COVID-19. People aged over 65 made up 87.9% of total deaths from COVID-19 during that period. And tragically, almost 100% of deaths in care homes. We also obtained data regarding positive cases of COVID-19 from the start to the end of the period of the inquiry's terms of reference. Public Health Scotland's data indicated that there were approximately 2.1 million recorded positive cases of COVID-19 in Scotland. It should also be noted that during the period of our consideration, there were 1,092 all-adult care homes in Scotland, with a total of 41,299 available places. As will be apparent from these figures, people over the age of 65 contributed disproportionately to the number of total deaths from COVID-19 in Scotland. The data discloses that in the first wave of the pandemic in March and April 2020, the weekly deaths where COVID was disclosed as either the underlying cause or a contributory factor peaked at 663 per week. And in the second wave, In December 2020 into January 2021, the weekly deaths peaked at 452. As was observed in our opening statement in relation to these hearings, COVID continues to claim lives. The number of deaths where COVID has been either the underlying cause or a contributory factor now stands as at the 16th of this month at 18,880. Can I give now some further data regarding long COVID, which of course has been something about which we've heard a good deal of evidence. We have heard a great deal of evidence concerning the impact caused by developing long COVID and its varying and debilitating effects on individuals. That evidence has come from individuals, including a number of individuals who contracted COVID in the course of their work in the health and social care sectors, and also from individuals speaking on behalf of their children. We have also heard from representatives of organizations speaking of the impact that long COVID has had on workforces, particularly within the health and social care sectors. Given that evidence, it seemed to us that we should seek to obtain some data regarding the prevalence of long COVID in Scotland during the period of our remit. Beyond a simple extrapolation from the number of people who have self-reported long COVID across the UK, our researchers have drawn to our attention certain research, which I will expand on in a moment, but which, subject to certain caveats, suggests that in the period between the 1st of March 2020 and the 26th of October 2022, some 90,712 individuals had long COVID, representing 1.8% of the population. This figure has been produced by the Usher Institute at the University of Edinburgh and is entitled, giving the full title of the work, Prevalence and Risk Factors for Long COVID Among Adults in Scotland Using Electronic Health Records, a national retrospective observational cohort study. The study looked at the electronic health records of all adults, being those aged 18 or over, and who were registered with a general medical practice in Scotland between the two dates that I've indicated. That cohort of individuals represents 4.7 million adults, or 98 to 99% of the population. 4 different methods were used to identify long COVID cases, and these were as follows. Firstly, clinical codes, where long COVID was specifically entered into a patient's records by their GP. Secondly, free text in primary care records, which would include notes or non-coded information recorded into a patient's records by their GP, for example, about the symptoms they are experiencing. 3, sick notes. 4, using a novel operational definition. This is a definition of long COVID developed by the study team at the Usher Institute, based on patients having a positive COVID-19 test and 2 or more features, being either symptoms, clinical investigations, or prescriptions recorded in a patient's records which are or were suggestive of long COVID. This information does come with a number of caveats which the Usher Institute themselves issue. It is thought that the findings are likely to be a substantial underestimate of the number of people who have been and continue to be affected by long COVID. This caveat reflects some of the challenges in diagnosing long COVID, about which we have heard a good deal in evidence, and inconsistencies in recording information in the electronic health registers, records. However, it is thought that this study does appear to represent the most complete data source for estimating the number of positive diagnoses rather than an estimate depending upon self-reporting. The study also discloses that several groups have been and continue to be disproportionately affected by long COVID. These groups include females, those aged in the general population between 38 and 67, those who are overweight or obese, those who are living with 2 or more underlying health conditions, those who are immunosuppressed, those who were advised to shield, those who were hospitalized within 28 days of testing positive for COVID-19, and those who were tested positive for COVID-19 before the Omicron variant became the dominant variant in the UK. I turn now to another background issue, but one which has been relevant throughout really all of our hearings, and which is, in our view, very significant, and that is grief and bereavement. We would like to say something about the information that the inquiry has garnered and heard about grief. Dealing with grief in the context of the pandemic and its restrictions has been a recurring theme throughout this, the evidence we've heard. We, of course, recognize that grief was poignantly expressed by those who lost loved ones to COVID-19. But it also affected those who were denied proper basic contact with their loved ones during the pandemic, and those who cared for residents and patients and who observed their suffering and, in many cases, death in distressing circumstances. The inquiry has had regard to research carried out into grief experienced during the pandemic, and in particular to prolonged grief disorder, PGD as it is referred. In this regard, the inquiry considered research carried out jointly by the universities of Cardiff and Bristol and published in a paper entitled Prolonged Grief During and Beyond the Pandemic, Factors Associated with Levels of Grief in a 4-time point longitudinal survey of people bereaved in the first year of the COVID-19 pandemic. It was produced by Harrop and others. We are very grateful to Ms. Morrison of the COVID Bereaved Group for providing us with a statement specific to this matter, in which she explained grief in the context of a pandemic and a reference to her own experience, and also to those of others within the Scottish COVID Bereaved Group. The work by Harrop and others focused on the factors which have an influence on PGD. These factors included the relationship to the person who died, the cause, expectedness, and place of death, the circumstances of death, and the disruption of the grieving process. The authors state as follows, and I quote, "It is recognized that a significant minority of bereaved individuals will experience more complicated and problematic grieving processes, including development of PGD. Essential characteristics of PGD include persistent and pervasive longing for or preoccupation with the deceased, associated with intense emotional pain, for example, sadness, guilt, denial, functional impairment, and atypically prolonged symptoms relative to cultural norms, lasting a minimum of 6 months post-bereavement." In her evidence and under reference to some of these factors, Ms. Morrison explained that in the unique circumstances of the pandemic, the trauma associated with death started before the death of the loved ones. And this was particularly in the early days of the pandemic, and it was associated with the anxiety about the safety of a loved one in a care home, which was ratcheted up, having regard to the frightening news emanating from Spain and Italy. The tension for family members and loved ones was exacerbated by constantly waiting for updates on the specific condition of a relative or a loved one, and the information concerning the presence or otherwise of COVID within the institution. The final moments with a relative or loved one, which we have heard about, were obviously distressing. For many witnesses, the final moments were hastily arranged, and in some cases, they were unable to be present at the moment of death. Miss Morrison put it thus: "Some of us were lucky enough to be there at the end, but even then, we were wearing gloves and masks. Even the final holding of hands was tainted in our experience because of the gloves. You couldn't even kiss them goodbye. You were there trying your best to comfort them, and even then, we couldn't do it properly." The inquiry heard evidence from witnesses who could not be with their loved ones at the moment of death, and witnesses expressed a variety of emotions in relation to that denial, including anger, frustration, and guilt. Pamela Thomas expressed it thus: "I feel like we abandoned him. We left him. My heart has been ripped out, and I will never be the same again. It makes me question everything." Death obviously occurred in a wide variety of places and circumstances. For those who acquired COVID-19 whilst living in the community and who were then moved into hospital, the circumstances were particularly alarming for that person and their relatives. There would be the departure from the home and the worry that the relative would never see that person again. We would observe that there was evidence that demonstrated poor communication in the lead up to and immediately following the death. Witnesses observed that while death occurred in that context, in the context of a national emergency, the common decencies were on occasions dispensed with. That said, there was evidence of communication at and around the time of death, which demonstrated compassion and understanding. A specific issue that emerged in the evidence was the prevalence of DNA CPR notices. We will look in more detail at this, given that it is specifically referred to in our terms of reference 2I. However, a number of witnesses complained that DNA CPR notices were placed on their relatives' notes without an appropriate level of consultation. We would observe at this stage what was said by Dr. Jennifer Burns of the British Geriatric Society, who stated at paragraph 59 of her statement that discussions around DNA CPR and end-of-life care generally and understandably can be difficult. And then I quote from her statement: "But it is so important that concerns are alleviated with good communication and trust in the health professionals providing care. A decision not to undertake CPR should also be part of a plan to describe what treatments are available and what might be useful, and these can be documented in records in the form of treatment escalation plans or in anticipatory care planning records." Excuse me. Coping with grief was not helped by the processes that had to be gone through in the immediate period after death. We have heard some highly distressing evidence as to what seemed to relatives to be the absence of the usual decencies which accompany death. While there were accounts that demonstrated that those engaging with relatives around the time of grief acted with compassion and understanding, and also on occasions witnesses who carers who went beyond what was at that time the restriction. But they acted with compassion and understanding, but there was also evidence of unnecessarily and unfeeling insistence regarding the removal of loved ones' possessions. Some witnesses returned to an empty house, and due to the presence of lockdown restrictions, were unable to engage with other relatives or friends to share memories and attempt to offer comfort in what were obviously trying and distressing circumstances. We also heard evidence from many witnesses regarding the restrictions in place on funerals, including the sealing of coffins and the restriction on the number of mourners in attendance. In certain cases, those restrictions caused family tensions, and family members had to take the invidious and difficult decision of who to invite to the funeral. Dealing with grief did not end with the funeral and the committal of the deceased's body. Restrictions on associations denied family members the opportunity of the normal physical comfort that association with other members of the family and friends could bring. There was also evidence of a lack of appreciation by certain health professionals and institutions in the period following upon death. As Miss Morrison put it, the expression cast adrift comes to mind. There can be little doubt but that death in the context of a pandemic was, for many reasons, a traumatic experience, both obviously for the deceased, but also for family members and loved ones left to mourn. Dealing with these experiences was exacerbated by the unthinking behavior of others. Those who were COVID deniers, those who were conspiracy theorists, and the events in Downing Street were, as Miss Morrison put it, the ultimate insult. Can I deal now briefly with another background but significant issue, and that is in relation to dementia. In amplification and clarification of the evidence that the inquiry knew had been obtained concerning the impacts on the elderly, particularly those in care homes, the inquiry sought and obtained evidence from Henry Simmons, the CEO of Alzheimer's Scotland, and Dr. Jennifer Burns, consultant geriatrician, who was, during the currency of the period contained in the inquiry's remit, the president of the British Geriatric Society. From their different perspectives, they provided the inquiry with considered and detailed information about the various challenges that are presented to those with dementia and frailty and to their carers. The evidence from these witnesses was required to be considered in its entirety, but at this stage we would wish to make the following observations. A, there is a dementia spectrum, at the far end of which are persons with advanced dementia and who require 24-hour care, whether in their own homes with the support of family members or engaged carers, or in care homes. Further along the spectrum were those who had been more recently diagnosed and where there was a desire to work with such people to assist with building resilience so that they could continue to live well and, if possible, to continue to engage in everyday community activities. There are, according to Mr. Simmons, potentially between 15,000 and 20,000 people developing dementia in Scotland, all of whom are at various stages awaiting a diagnosis. B, the impact of lockdown and associated measures fell on carers, family members, and the stress that they were under was, in Mr. Simmons' assessment, huge. C, the information which Alzheimer's Scotland obtained in the early days of the pandemic from those it assisted with from those it assisted that the organization became stronger in saying that the impact on people was so significant that the organization was seeing people in the early stages of dementia advancing to a more advanced stage rapidly. In this regard, Alzheimer's Scotland identified a number of significant factors, including the impact of social isolation and loneliness, the loss of usual support networks, the impact of not being able to spend time with family members in care homes, with, and in our view, significantly, and I quote, substantial levels of anxiety and emotional trauma for both families and people with dementia. D. Mr. Simmons expressed his personal view in his statement at paragraph 68 that, and I quote, the public health concerns and focus remained for too long the driving force for decision-making, and that impacted people in the most profound way. E, that the data provided by Alzheimer's Scotland was that there were 29,485 long-stay residents in care homes in Scotland, and that of that number, 18,500 had dementia. F, that the image of someone living with dementia is as someone who is frail and elderly, but a lot of people were active and wished to remain involved in social activities. Being confronted with staff, this is point G, being confronted with staff wearing face masks would likely have had an impact on the well-being of residents. Again, I quote from Mr. Simmons. Someone living with dementia, even advanced dementia, struggles to have a sense of time, place, and person. When looking after someone with dementia, you need to help them with a sense of self and well-being using reminiscence techniques, social stimulation, cognitive stimulation. This is all mainly done in a care home environment on a group basis. And quote is from paragraph 74 of his statement. Point H, that the news emanating from Spain and Italy in the early days of the pandemic gave rise to a realization that the virus could have a devastating effect on people in care homes, and that it was likely that in Scotland, older people would be very vulnerable, particularly those who are living with frailty. Frailty is a distinctive health state relating to the aging process in which multiple body systems gradually lose their inbuilt reserves. Around 10% of people over 65 have frailty, rising to between a quarter and a half of those over 85. Older people living with frailty are at a risk of adverse outcomes, even after apparently minor challenges to health, such as infection. Excuse me. People living in care homes are likely to have more advanced levels of frailty. Point I, that the lack of universal testing and delay in recognizing the variation of symptoms in older people left older people exposed to underdiagnosis in the early stages of the illness being COVID. The mortality rate from COVID infection is very age-dependent and higher if the person is frailer and has complex comorbidities, as was the case with many hospitalized older people and care home residents. Point J. Patients, residents with dementia are more likely to suffer from delirium if acutely unwell, with illnesses such as COVID, leading to a more confused and agitated state, thus making it harder to keep them safe in an environment. Conversely, delirium can cause people to become very sleepy and to stop eating and drinking. point K, Dr. Burns observed that the term vulnerable was a blanket term used to apply to older people, and as such was a shock to many people who were happily living their lives. A report by Age UK on the impact of COVID-19 on older people's mental and physical health commented on anxiety related to the risks from the virus, resulting in many older people being afraid to go out and resume previous activities, even when restrictions had ended. Lockdown affected many older people's ability to undertake activities such as regular exercise, social interaction, and a sense of purpose, and the longer-term impact is likely to be negative for their physical and mental health. Point L. We would wish to quote in full what Dr. Burns said at paragraph 70 of his or her statement. I quote, "Care homes are an individual's own home, and as the pandemic eased, restrictions eased in many settings, but were slower to relax for those living in care homes. Social isolation is harmful to care home residents and can result in low mood or cognitive or functional decline. We were restrictive for a lot of the pandemic for reasons that at the time I, that being Dr. Burns, supported. But on reflection and feedback from members, I consider that these restrictions were too prolonged. Visiting policies should take account of the benefits and the risks to the individual resident, the potential risks to the wider care home population, and the current prevalence of COVID in the surrounding community. As testing capacity increased, a rollout of testing for visitors to care homes should be added to the strategy to provide some reassurance." End quote. Another factual matter that I would like to discuss is the evidence that we've heard relating to the transmission of the virus by airborne means. In the course of evidence in these hearings, we've heard reference made to this significance, and it has an oblique bearing on the impacts incurred in the health and social care sector, particularly in relation to the suitability and availability of PPE. This issue concerned the mode of transmission of the SARS-CoV-2 virus. A number of witnesses referred to that issue, and I make particular reference to the evidence of Dr. McCaskill of Scottish Care, Dr. Ian Kennedy of the BMA Scotland, and Colin Pullman, Norman Provan, and Aileen McKenna of RCN Scotland, and also various witnesses from the STUC. From these witnesses, there has been a considerable body of evidence to the effect that in the early stages of the pandemic, there was an intransigence on the part of the Scottish Government to accept the emerging, and it is said, compelling scientific evidence that COVID-19 was transmitted in an airborne or aerosol manner rather than by droplets. The RCN was sufficiently confident by March 2021 to present to the Scottish Government a case that the virus was transmitted in an airborne manner, a case backed up by international scientific research. The apparent failure of the Scottish Government to accept this submission was referred to in the evidence of Dr. Kennedy of the BMA as adherence to what he described as, and I quote, droplet dogma. This is clearly a matter which the inquiry will wish to investigate further in its implementation and decision-making hearings. The inquiry is aware that the World Health Organization, on the 23rd of December 2021, on its website, under the heading Coronavirus COVID-19, How is it transmitted?, stated that, and I quote, current evidence suggests that the virus spreads mainly between people who are in close contact with each other, for example, at a conversational distance. The virus can spread from an infected person's mouth or nose in small liquid particles when they cough, sneeze, speak, sing, or breathe. Another person can then contract the virus when infectious particles that pass through the air are inhaled at short range. This is often called short-range aerosol or short-range airborne transmission. Or if infectious particles come into contact with the eyes, nose, or mouth, droplet transmission. The virus can also spread in poorly ventilated and or crowded indoor settings where where people tend to spend longer periods of time. This is because aerosols can remain suspended in the air or travel farther than conversational distance. This is often called long-range aerosol or long-range airborne transmission. People may also be infected when touching their eyes, nose, mouth, after touching surfaces or objects that have been contaminated by the virus. The inquiry is aware that this alteration to the World Health Organization guidance has been criticized for its lateness and the manner in which it was disseminated, which was described as being, quote, quietly edited, unquote. I now turn, if I may, to the position of those in care homes. At the outset of our investigations and in planning for these areas that we wish to consider the impacts of the pandemic and associated restrictions, the inquiry team made a positive decision that we would endeavour to consider the impacts on those who were the most vulnerable in society. In identifying such groups, we were guided by our trauma-informed and human rights-based approach, and also by term of reference 7C, which provides that the inquiry will, as the chair deems appropriate and necessary, consider any disparities in the strategic elements of handling of the pandemic, including unequal impacts on people. A vulnerable group specifically identified for our consideration was and is, of course, those who are residents in care homes and nursing homes. And in that connection, the inquiry was directed through the wording of term of reference 7G to considerations of issues relating to the transfer of residents to or from homes, the treatment and care of residents, and infection prevention and control. Other vulnerable groups included those who were disabled, both in care institutions and in the community. Those who were socially and or economically disadvantaged. Those who were required to shield. Those who were homeless. Those who were drug and or alcohol addicted. And those who were in custody. The inquiry is also grateful for the participation in these hearings by the Scottish women's rights organisations and the evidence provided by the panel from those organisations in support of their statement has been extremely helpful and again will inform work going forward. Of particular concern to the inquiry is to learn of the impact on both women and children where, because of lockdown, they were confined, as it was put, trapped into a home with an abusive partner. It will be appreciated that residents in care homes largely comprise those who would be described as elderly. And as will have been apparent from the evidence we have heard, the evidence conveying the impacts on that group came principally from their relatives. We should note that not all care home residents about whom we've heard were elderly, and we heard moving accounts of the effects of the pandemic that restrictions had on the children of witnesses within the care home relatives group. We should also observe that while the focus was properly on the impacts on the residents, the evidence also disclosed the impacts on the relatives, who, for substantial periods during the period of our consideration, were forced to wonder and speculate about the condition of their loved ones at times when visiting was prohibited, and on other occasions had to view their loved ones either remotely or from distance without the ability to physically interact with them. While many spoke stoically of their experiences, the impacts of these events on these relatives cannot be underestimated. As has already been mentioned under reference to the evidence of Mr. Simmons and Dr. Burns, and has been pointedly emphasized by many relatives, the care home is not a clinical setting. It provides a home for the resident, and many witnesses spoke of the steps that have been taken to personalize the resident's accommodation. Prior to a resident moving into care, their family members had frequently been the care providers, and aftercare in a care home setting became essential, and prior to the pandemic, relatives had frequently been involved in assisting with care in the care home setting. The immediate closure of care homes in March 2020 was, as many witnesses testified, a devastating disruption of normality for both the residents and the relatives. On occasions, the circumstances in which homes closed did not allow for any period of adjustment, or where it might have been possible to give some explanation of the reasons for closure. Many witnesses spoke of the immediate cessation of contact with their loved ones, and while in some cases some form of continued contact was possible through the use of communication devices, in many cases the isolation of the resident was complete, with the exception, obviously, of contact with people within the care home. That inevitable degree of uncertainty as to the effect that isolation was having on the resident compounded the concern that relatives had about their loved ones. A number of witnesses spoke of the adverse effect that the period of complete isolation had on the resident in terms of both of their physical and mental well-being. Subsequent alleviation of isolation did occur through window and garden visits. While those did afford welcome opportunities for relatives to see their loved ones, there were many criticisms of such visits. Windows were frequently in locations and at elevations which made sightlines between visitors and residents difficult. There were obvious problems with relatives in particular making themselves heard. For those residents with dementia, their loved ones often felt that the strangeness of the arrangement caused the resident distress. Weather conditions, inevitably, and often presented problems. The privacy of conversations was often compromised. Garden visits were frequently a euphemism for meeting outside. Evidence of visits of these types revealed an understandable cause of frustration for relatives. Residents were regularly accompanied by carers during such visits. Indeed, the impression was occasionally given that such visits were being policed by carers. Indeed, on other occasions, the word imprisonment was used. For relatives, the fact that carers could be next to their loved ones, touch them, offer them comfort, while they, the relatives, were denied that basic interaction seemed understandably both inconsistent and unfair. Underlying the sense of grievance felt by relatives was the knowledge that their presence as part of the care team for their loved one could help reduce the pressure on the care home staff provide a familiar face for the resident and the assistance of somebody who is intimately familiar with the resident's routine and likes and dislikes, and who would take whatever precautions were necessary or deemed necessary and appropriate to protect their loved one from infection. As has already been alluded to, many witnesses spoke of noticing a marked deterioration in the physical and mental well-being of their loved one following upon extended periods of isolation. This deterioration was understandably attributed to the isolation. It should be appreciated that compliance with restricted access to a loved one had an adverse effect on their well-being.
Mr. Gale, I appreciate it's a little early, but
Yes.
you're well ahead of schedule.
Well ahead of schedule, and there's not very much to go, my lord, but I would welcome a break at least.
And we could be indulgent and have a little longer.
Yes.
So instead of 15 minutes, we'll take about 25 or something, and we'll come back at 11:15.
Thank you, my lord.
Thank you all. Good. Right. Now, Mr. Gale, when you're ready.
Lord, yes. Lord, I'm about to move on to the subject again. It's seen as a background subject of communication and guidance. Now, throughout the hearings, an issue that has been presented on a number of occasions and in a number of different contexts is that of communication. And at this stage, I would like to refer to a number of contexts. Firstly, guidance provided by authorities has frequently been referred to and criticized. In particular, there has been considerable evidence from those who are required to understand guidance issued by authorities, which regulated the circumstances in which those in care could be visited. That evidence came from those who wanted to visit and from those who were required to act in accordance with this guidance in providing care facilities. A recurring criticism was that the guidance was subject to constant change, such that all who were required to understand the guidance had difficulty in knowing what, at any particular time, was the current guidance, and this was frequently compounded by guidance being issued at the end of the week. Also of concern was the criticism made by many witnesses that the framing of the guidance was designed for, or more for, application to the circumstances of acute clinical settings and did not properly take account of the care settings in which mainly elderly residents, many of whom suffered some level of dementia, could not be expected to observe the restrictions more appropriate for clinical settings. This is an area of communication between authorities and the public, which is, in the inquiry's view, a significant one having regard to our terms of reference. The inquiry is going forward to its investigations around implementation and decision-making, conscious of the informed criticisms made by parties and witnesses in the impact hearings. The inquiry does not think that it can be disputed that there exists and existed an obligation on governments and authorities to express guidance with clarity and certainty. The inquiry has recently considered the report issued in May of this year by the Independent Commission on UK Public Health Emergency Powers, published by the Bingham Institute for the Rule of Law. While relating principally to the use by governments of primary and secondary legislation in the context of dealing with the pandemic, the Commission makes the following comment in its executive summary. Legal certainty is a key aspect of the rule of law. In order for people to understand what the rule of law requires them to do, legal rules must be sufficiently clear, stable, and accessible, and should enable people to foresee with reasonable confidence when they might be sanctioned for not following the law. The main areas of legal uncertainty that arose during the COVID-19 pandemic include 1, uncertainty caused by the manner of making and frequently amending large numbers of public health regulations, and 2, uncertainty caused by the way legal requirements and public health advice were communicated by the government, often without clearly distinguishing between the two. The inquiry will, as I have said, investigate the way in which guidance was presented and communicated to the public, and in particular we will examine the status, whether actual or apparent, given to that guidance. On a more micro but no less important level, the inquiry has in these hearings heard considerable evidence concerning the way in which care institutions communicated with relatives of loved ones who were in care and who, understandably in circumstances where they were unable to see their loved ones, wanted to know about their conditions. The evidence that we have heard has disclosed varying levels of communications. There have been instances where communication and the information conveyed were both helpful and compassionate. There were, however, concerning instances where calls went unanswered or was responded to only after numerous repeated calls. On other occasions, responses were non-specific and formulaic, with the words such as, yes, he or she is fine, deemed to be sufficient to satisfy a concerned relative. Even allowing for the exigencies under which staff were working, such responses of that nature we pose the question, could those responses be considered either adequate or appropriate? A specific issue regarding communication arose in connection with the presence on the records of a patient resident of a DNA CPR notice. It will be appreciated that the inquiry's terms of reference direct that we should investigate the strategic elements of the handling of the pandemic relating to the delivery of end-of-life care and the use of DNA CPR. For a number of witnesses, it was accepted that such a notice had been discussed either with them or with the patient resident and had been included in the records on an informed basis. A number of witnesses, however, expressed both shock and distress to discover that a DNA CPR notice existed in respect of their loved ones. that such should have been the case without apparent consultation with the patient and or family members is a matter of concern, and the inquiry will take forward the detailed evidence of these witnesses to our future consideration of term of reference 2I. We will also, in consideration of implementation and decision-making, consider the protocols and guidance that were in place concerning the use of DNA CPR notices. The pandemic led us all to communicate through different methods and using, with varying degrees of success, I have to say, different types of technology. This inquiry could not have conducted its business without resort to remote means of communication. We have heard throughout our hearings that telephones and tablets provided means of communication between relatives who could not access their loved ones in hospitals or care institutions. As would be anticipated, the success of such means of communication varied depending largely on the patient or resident's ability to use the device and also to have the cognitive ability to understand why it was their loved one who was on a screen and not physically present with them. We have heard evidence that on occasions use of devices caused patients and residents confusion and distress, which was reciprocated for the relative on the other end, albeit that they had an opportunity to see their loved one. We also heard of the impact on those calling in when they could see a carer in the institution, in close proximity to the resident when aiding them to use the device, a fact which brought home to them what appeared to be the iniquity of the situation without being in any way critical of the carer. There were people who, for various reasons, did not have access to technology or the ability to use it. This led, particularly within the community, to an increased sense of isolation and loneliness, exacerbated if the person was disabled and restricted in their ability to leave where they lived. Obtaining deliveries of essential supplies was possible through the use of digital ordering, but again, this was dependent on the availability of a digital connection and a device for communicating. It was also made clear that certain suppliers had a minimum cost of supply, which certain people could not afford or did not require. We heard of the efforts of organizations, particularly within the third sector, who not only kept in touch with the most vulnerable in society, of whom they were aware, but also fill the gap where provisions were needed. I'll deal briefly, my Lord, with the availability of PPE. As will be appreciated, term of reference 2E directs the inquiry to consider the strategic elements of the handling of the pandemic insofar as they relate to the supply, distribution, and use of personal protective equipment. The inquiry will conduct specific investigations and hearings into this issue, and indeed this is ongoing. There has been in these impact hearings a considerable body of evidence relating to PPE, and in particular evidence from both individuals and organizations relating to the availability of suitable PPE for workers in the health and social care sectors. That evidence will inform our investigations going forward. In particular, we have heard evidence from the representatives of various organizations complaining of the absence of sufficient quantities of appropriate PPE, the use of PPE which was out of date, and the lack of suitable PPE for a diverse workforce. We move on to consider the impact on members of staff in the health services. In the hearings which have taken place during the present calendar year, the inquiry has heard from individuals who provided services in health and social care sectors, and those who represented those working in those sectors. We have also heard from those who were unpaid carers, who all represented such carers. We have also heard from the STUC and its affiliate unions, from organizations within the third sector, from representatives within the NHS and from the private sector, and we have heard from professional organizations on behalf of their membership. It has been important to secure from these witnesses the perspectives of those who were engaged in the health and social care sectors during the pandemic. Of particular interest was to understand the different approaches in the public and private sectors. The inquiry has been particularly concerned to note the effect that working through the pandemic and its attendant pressures had upon the physical and mental being of the health and social care workforce who worked through the pandemic and its attendant stress and pressures. The inquiry is very grateful for those representing various organizations and individuals who have provided us with their thoughts in the form of their closing statements. In addition, I am grateful to colleagues in the council team who have each provided us with detailed assessments of the various witnesses they led. In addition to the assessment of the evidence provided by witnesses who worked within the health and social care sector, we have also been provided with detailed assessments of the evidence concerning the impacts on the asylum and refugee community, including within that community women who are pregnant, those who are in custody, those who are in homeless and or alcohol, who were homeless and or alcohol and drug dependent, those who are in receipt of end-of-life care, including those who were residents in hospices, those who were shielding, children who were in need of protection and looked after and accommodated children, those who are in receipt of assistance from organizations within the third sector, and those who are in receipt of care within the community, and in particular those who were cared for by unpaid carers. With this evidential basis, the inquiry is satisfied that its efforts to secure a comprehensive foundation of knowledge regarding impacts to proceed with confidence to the next stage of our investigations. I repeat again our thanks and gratitude to all witnesses who have assisted us in this task. My Lord, finally, after that, there is one further thanks I should make, and that is to my Lord for the direction that he has given throughout these hearings, and we as the inquiry team are very grateful. Thank you, my Lord.
Very good. Thank you very much indeed for that presentation, Mr. Gale. We are, of course, ahead of schedule, but that gives us the benefit of having a slightly extended lunch break. We're back at 2 o'clock with presentation, firstly from the Scottish Ministers, when we hear Mr. Mitchell, KC. Thank you very much indeed. 2 o'clock.